many of these occult dysraphic problems remain challenges in decision-making and technical expertise. And we have an excellent panel, and I'm super pleased to introduce our moderator today. We were all thrilled when Dominic Thompson agreed to be the moderator. Dominic has taken these issues and made it kind of the academic center point of his recent life. When he talks on these issues, it reflects that he's really made a commitment like few others to trying to learn the nuance, wrestle with the challenges and whatnot. He practices at Great Ormond Street in London and has been a prominent member of the ISPN for years. So we welcome all of the speakers. We appreciate everybody's attendance. And with that, I'll turn it over to Dominic, with my last statement being that my only further contribution is to be the timekeeper enforcer. So please, speakers, because we have so many, do your best to stay to time, and I'll only bug in as need be for time. So otherwise, with another word of thanks to Arthur, I'll turn it over to Dominic. Dominic?
Jeff, thank you very much indeed. And please, let me echo great thanks to Arthur. I mean, as you say, put down a great and a very diverse program here. And, I think I cannot, overestimate or extend really on what Jeff has just said. I think for any young neurosurgeon, this is probably, one of the consistently most controversial areas of pediatric neurosurgical practice. And I really don't think that is hyperbole. Therefore, I think it's so important to be listening to, you've got some great speakers today. You'll cover most of the spectrum of occult spinal dysraphism today. So please put up your questions on the Q&A, and I will try and integrate those to the speakers on your behalf. So I don't want to take up any more time, so it's important that we get on. And to start off this session, it's a great pleasure to introduce my longtime friend, Martina Misegiunger from Germany, who's going to start off by giving us an introduction to the subject of occult spinal dysraphism. So Martina, thanks very much, and please fire away.
Yeah, thank you, Dominic, for this very kind introduction. And of course, many thanks to Arthur and to Jeff for organizing this fantastic series on any topic which is important in pediatric neurosurgery for our young colleagues. And also thank you to ISPN, to Linda, for the support. So our today's topic is occult dysraphism, and I am going to give you a very brief but common introduction into the subject. And it's not everyone's darling, but we have to look into embryology, but very, very briefly. So the stages which are involved in the formation of these kind of malformations are the stage of gastrulation and neurulation. And the whole thing starts in week 3, when from the 2-layer blastocele formation, which is quite complex, into a 3-layer with all the primary germ layer issues takes place. And this is in essence the formation, or specifically, of the mesodermal structures. And these structures primes organogenesis. And organogenesis, the part we have to look at is neural tube formation. And this happens then in week 3 to 4 with primary neurulation. And this is the phase where the neural tube is formed from the anterior down to the posterior neuropore. We will see what this is giving rise for. And then it is followed by the secondary neurulation in week 5 to 6.
You screen sharing your full presentation, because I'm only seeing the introductory slide at the moment.
I am having it. Sorry, I am having this on my slide here. It's completely perfect. So I go back. Probably you can see this now.
Go to mode as well, please. That would be great, Martina.
You see now embryology?
Yes.
But okay. And sorry for this. I was not aware of this. So I just go back. This is the gastrulation phase, where we have the 2-layer formation developing into a free germ layer formation, and the important formation of the mesodermal structures happens during this stage. And this is very important since it is priming organogenesis, this stage. And the part of organogenesis we are looking at now is, of course, neurotube formation. And this happens during primary and secondary neurulation. Primary neurulation starts in week 3 to 4, beginning at the anterior neuropore and going down to the posterior neuropore. And then following week 5 to 6, secondary neurulation will be responsible for the very lowest part, caudal to the posterior neuropore, and this is responsible for the majority of our occult lesions. Open spinal dystrophism happens, as already said, during primary neurulation, and whenever something happens during this phase, we have anencephaly down to myelocystocele and some other malformations as well. During secondary neurulation, which is a much less organized stage compared to primary neurulation, where the very caudal part is going through regression processes, occult spinal dystrophism occurs with all the different subtypes we will learn much more about in the upcoming presentations. Split cord malformations, which is also a topic of today, is not essentially a problem of organogenesis primarily, but of course the expression will also affect the neural tube formation. But the primary cause is a misled structurizing of the mesodermal structures, and it is assumed that a widening of the primitive streak during gastrulation will interfere with the proper notochord formation. So we have a kind of split formation, and accordingly the neural tube structures have to follow then this double sides. All of these lesions have one problem in common, and this is the tethered cord. And this has been first described by Garceau in the 50s. And in 1976, Hoffman and co-workers defined for the first time the tethered cord syndrome. And Yamada and co-workers afterwards started to do extensive research on the pathophysiology which is associated with the tethered cord. Any of these malformations we will learn about today will more or less lead to spinal cord tethering, but also other lesions can be the cause. In spinal cord tethering, a reduction of oxidative metabolism, blood flow, and glucose metabolism has been found, and this leads finally to neuronal damage. And if this is associated with natural things like growth spurts in younger individuals, and later on also in physical stress and in adulthood in with spinal degeneration, clinical symptoms may occur early or during the long run, but not probably in all the cases. Just have a brief look at the diagnostics. Of course, we have our MRIs and so on, but before someone gets the idea that a patient has to undergo this kind of tests, very important clinical assessment and also asking for the history should happen. We have to look for stigmata. We have to look for asymmetries of legs, feet, or the gluteal region, and also thorough orthopedic assessment is important. Looking for progressive foot deformity, specifically in children that start to walk, and over the time also neuromuscular scoliosis could be another thing an orthopedic assessment could demonstrate. neurophysiological tests, and very important also urological tests, because most of the cases that are probably clinically not affected may harbor urological problems, and these can be very subtle and can only be assessed by proper urodynamics. And most of the patients only have this kind of neurological malfunctions. These are stigmata that can be found: subcutaneous lipomas, cutaneous hemangiomas, skin appendages, and also asymmetric skin folds or anal folds, asymmetric legs and feet, as already said, but also hairy patches or other skin lesions, and also everything together in one patient. By the way, hairy patches are pathognomonic for split cord malformation, but also very subtle stigmata like sacral dimples or coccygeal pits might be associated with a tethered cord with a low conus and filum pathologies. Some reports tell us that up to 1/3 of the patients might harbor such a lesion. So, as already indicated by Dominic, this is a very controversial group of diagnosis, specifically in respect of the role of surgery and the timing of surgery. Is there a role for prophylactic surgery in asymptomatic children in one or the other entity? There is a lot of publication and debates in our meetings. The most important debate was the clash of the titans during the Liverpool meeting. I think it was in 2008. Am I right, Dominic? In Liverpool, between Dagny Pang and our late friend Michel Serrat, about whether we have to operate on lipomeningocele prophylactically or not. And I'm pretty sure that this will be part of the ongoing discussion during this session. So I thank for now and wish you all together a fruitful webinar. Thank you. Dominic, you are muted.
Thank you very much, Martina. Thank you. Well, thanks very much, Martina, for that's giving us a really nice sort of overview, if you like, setting the broad spectrum of what is occult spinal dysraphism. And I think one of the things that Martina brought out is that this concept of tethered cord, it doesn't refer to a specific diagnosis. It's referring to a clinical syndrome. And the rest of the speakers now are going to talk about some of the entities that may or may not end up giving you a tethered cord syndrome, and the natural history is going to be very different in many of these. So I think if we may move on now, and the next speaker, I'm very pleased to introduce Kamel Gotme from Colombia. And Kamel, you're going to start off on possibly the most controversial area, that of the lipomyelomeningoceles. So please, Kamel, thank you for joining the webinar, and please share your screen and start your talk. Thank you.
Thank you, Dominic, and thank you all for attending this webinar. I'm so pleased to be in part of this distinguished group of panelists. And I'm going to talk about lipomyelomeningocele, which is one of the occult dystrophism conditions that we can face as pediatric neurosurgeons. I want to confirm that I'm sharing the screen.
Yep.
Excellent. So conflicts of interest related to this presentation, and the learning objectives are to review the main pathophysiological and clinical characteristics of lipomyelomeningoceles, discussing the decision-making process, presenting the main surgical aspects, and analyzing post-operative and complication risk. This is our agenda for today, and let's go straight to the topic with some general aspects. A lipomyelomeningocele is a closed neural tube defect, so it's an occult form of dystrophism. It can be a complex condition with a potential neurological compromise due to a tethered cord. This means that we can have these conditions, and the patient not necessarily will have a neurological compromise or abnormality. The treatment strategies vary depending on the subtype, neurological function, and surgical goals. Let's see some epidemiological aspects. Neural tube defects in general are present in 1 to 3 of every 1,000 live births. Spina bifida aperta, like an open myelomeningocele, which is not the topic of this course, is present in 5 to 6 of every 100,000 live births, whereas spina bifida occulta occurs in 12% of the general population. And from those, 0.3 to 0.6 per 10,000 living births will be a lipomyelomeningocele. These defects account for 14% of all spina bifida cases. When we have a lipomyelomeningocele, we probably have another condition associated in a certain proportion of the cases. We will see Chiari malformation type 1 in 13% of the cases, spina bifida aperta 14%, Diastematomyelia 3%, a dermal sinus 3%, dermoid or epidermoid cyst in 3%, terminal hydromyelia 3%, anal stenosis 1%, and it's even been described associated with Down syndrome in 1% of the cases. What's the pathophysiology of this specific condition? Lipomyelomeningoceles occur due to errors in secondary neurulation. This is very important because most of the open spinal defects on the defects in the closure of the neural tube occur during the primary neurulation, but this is one that happens during the secondary neurulation, or an abnormal or incomplete regression of the caudal cells mass. This is why it's also part of what we call caudal regression syndrome in some cases. Lipomatous tissue is incorporated into the conus medullaris or the filum or the phylum. Sergio, in the next talk, will specifically address phylum terminale lipomas. Lipomatous tissue, not neural elements, herniate throughout the dorsal spinal defect and adheres to the subcutaneous mass. The fatty tissue may cause a local mass effect on neural elements or traction on the conus, with or without evidence of a low conus. So this is also important. When we have a lipomyelomeningocele, the level of the conus medullaris can be even in the normal level, L1, L2. Not necessarily it will be associated with a low conus, and although most cases may have a tethered cord, this is also not always the case. In this image, you can see that the closure of the caudal neuropore and the formation of the caudal eminence is one of the key processes that can be affected. And in this graph, you can see that primary neurulation is followed by the secondary neurulation, but in the middle, we have a junctional neurulation. Lipomyelomeningocele usually can happen during the junctional stage or the secondary neurulation stage. Chapman classification is one of the most used for lipomyelomeningocele, and we have 3 main types of lipomyelomeningocele: dorsal, caudal, and transitional. The most frequent one is the dorsal lipomyelomeningocele, in which we will find an attachment to the dorsal spinal cord in the area of myelocystocele. That happens in the lower lumbar or lumbosacral region and continues with the subcutaneous tissue. The lipoma traverses a facial defect and they extend and expand the central canal. So you will have intraspinal fatty tissue that can herniate and go outside subcutaneous tissue. And there is always a dural defect, and the black hole lipoma interface may be in the extradural space. So there is a place in which the neural tissue ends and the fatty tissue starts. That's the interface. And this interface can be inside the dura or most frequently outside the dura. Then the transitional myelocystocele to the conus with a less distinct lipoma cord interface. So the interface can be more blurred in this case. It also extends across the dural defect, so you can see the fatty tissue going out in the subcutaneous plane. And finally, the caudal type arises predominantly from the caudal end of the medullary cone and may extend throughout a dural defect or may be contained within the dura mater. So this could be intraspinal alone without having a dural defect. So again, you have the 3 types here. So the dorsal one, this is posterior, this is anterior, this will be in the dorsal aspect, and there will be a clear interface. During the transitional, that interface is blurred, and the caudal one will be in the most caudal end of the neural cord, and usually the spinal cord will be split, will be open or expanded in this point. Morota also described another classification according to the embryological stage, and if it happened at the end of the primary neural lesion, then you will have usually an open defect with the fatty tissue condensed in the subcutaneous layer. Also, if it's in the junctional stage, the defect is going to be more predominantly on the caudal end, and it can be a defect in an early phase of the secondary neural lesion or a late phase of the secondary neural lesion. I personally prefer the first one, the Chapman classification, because that helps us to plan the surgical treatment. We will see cutaneous stigmata, such as subcutaneous lipomas, hemangiomas, dimples, hypertrichosis, appendages, as the cases that I'm showing here. This is a hyperchromic macula and a subcutaneous lipoma. And you can see also subcutaneous hemangiomas, hypertrichosis, a lipoma itself, dermal sinus with a little hole, and a skin appendix like this girl. Also, musculoskeletal abnormalities such as scoliosis, foot deformities, abnormal rotation of the foot or the leg, and asymmetry. Neurological abnormalities such as chronic leg or back pain that can be at rest and can worsen with activity, weakness in lower limbs, sensory disturbances, and gait abnormalities. Of course, neurogenic bladder and bowel. And how do we assess these patients? We need to make a complete pediatric medical history, make a general physical exam to detect other neurocutaneous signs or other findings such as scoliosis, lower limb deformity, signs of caudal regression, or bacterial association, and make a complete neurological exam. For lab tests, we study the urine, complete blood count, coagulation tests, and differentiated proteins to assess the nutritional status of the patient. For the bladder function, we're gonna make renal and urinary tract, ultrasound, urodynamics, and urography. Electrodiagnosis for young kids sometimes requires general anesthesia, but for older kids, we can do it without. We can do electromyography, neural conduction, somatosensory evoked potentials, and anal and bladder electromyography. And of course, imaging is the key for diagnosis and assessment to make the therapeutical decisions. This is a non-enhanced lumbosacral MRI where we can see the adipose tissue is starting in the intraspinal canal and then making a herniation through the dural defect and the posterior arc defect and going to the subcutaneous tissue. As Dominic mentioned, this is one of the most controversial topics in terms of when to operate and when not to operate. I'm going to show you our process of decision-making that can be shared by many groups, but some groups still argue that for some cases, they would manage differently. So conservative treatment is the first choice in every asymptomatic patient. First choice means that it's not the only choice, but you always start giving the chance of making a follow-up close observation. Up to 30%, 70% of the patients may remain asymptomatic in the long term. So we start seeing them at 4 or 5 years, and at the age of 15, continue asymptomatic. So that means that the natural history of disease not necessarily imply that they will deteriorate. And when patients have mild and stable symptoms, because most of them will have urinary tract infections, but it's compensated, it's once in a while, they may also benefit from conservative management. But conservative doesn't mean passive follow-up. It means a strict and active follow-up with periodical assessment of complete history and physical exams, spine alignment, bladder and bowel function, and paraclinical tests. Prophylactic surgery, in our opinion, is not indicated as it is associated with late deterioration. 40 to 60% at 12 years after surgery have had some sort of complication, retethering, and need of re-interventions, and generates tissue fibrosis that could make future interventions difficult. When do we operate? When we have progressive pain in the spine and lower limbs, progressive spinal deformity, progressive deterioration of bladder and bowel function, gradual deterioration of motor sensory function, or a need to detach a tethered spinal cord before a corrective surgery for scoliosis that will cause trunk elongation and that will probably cause additional stress to an already tethered cord. This is an algorithm proposed by Wykes and collaborators in 2012 that we pretty much base our decision-making tree. So we make clinical history, exam, MRI, and neurological evaluation with a lumbosacral lipoma or lipomyelomeningocele. If they are asymptomatic, we do close neurological and urological surveillance, and if there's deterioration, we go for surgery. But if they remain asymptomatic, we continue observing. If they are symptomatic from the beginning, we follow up, and if those symptoms are static and very stable in months and years, we may also observe. But the symptoms are progressive, then we go for radical surgical intervention. A few words about the surgical technique. We make intraoperative electrophysiology monitoring in all cases. We do motor and somatosensory evoked potentials. We measure the anesthetic depth, anal electromyography, electromyography of the lower limbs, and bladder catheter during the procedure. We use electrical stimulation of intradural structures to determine if it's fibrous tissue, filum terminale, or nerve roots. We prep the patient in prone positioning. We protect pressure zones. We make a demarcation of the incisions. We always use microscopic vision. And then for a dorsal or transitional lipomyelomeningocele, we use durotomy and dural separation of the lipoma. So we separate the dura first, and then we dissect from caudal to cephalad until the medullary cone is visible. So we start caudally and we separate from the structures until we see the cone. We make a careful dissection of the rostral portion. You see here the difference between the neural tissue and the fatty tissue. And we might leave some small residuals of adipose tissue attached to neural or vascular structures to prevent the possibility of harming those structures. We release the roots and the cones, and we close with a watertight closure of the dura. For caudal lipomyelomeningocele, we will find an open and expanded medullary cone. So the main objective is to untether the lipoma and the medullary cone, and then we continue doing the dissection by also making electrical stimulation of structures before cutting anything. We close with PL stitches with 4 or 5 observable vicryl, just to cause a neural lesion, which is a tubular myeloplasty of the medullary cone, and make it as it should be if it wouldn't have the lipomyelomeningocele. For the closure, we make all planes, duroraphy, aponeurotic plane, subcutaneous plane, and the skin with the sutures and type of stitches that we mentioned there. And for post-op care, all patients go to the pediatric ICU. We use multimodal analgesia. We remove the catheter as soon as we can, usually the second day, and we assess if the patient needs intermittent catheter or not, high fiber diet, stool softeners. We monitor CSF for CSF fistulae. We isolate the surgical site with Tegaderm during the inpatient stage to prevent contamination with feces or with urine, and we transfer to the ward and start early rehab. We've seen complications that are potential and luckily have a low rate of complications due to strict protocols, but there can be infection, CSF fistula, ischemia or necrosis of the skin flap, neurological deterioration, or lately we can have a new spinal tethering or need for re-interventions. This is one of the few complications, and it's a small hematoma in the surgical site due to the dead space and the thinning of the skin after removing the subcutaneous tissue. So we manage this with prone position, like a long prone position, and heparinized gauze until it got normal. I would recommend these 3 articles as a complementary reading to this talk. And I want to thank you all. These are my contact details in case you need additional information, but I'll be here connected to see if there are questions in the Q&A. Thank you so much.
Well, thank you very much indeed for that overview of the lipomas. And just before we move on to the next question, you talked about the Marotta classification and the Chapman classification into the different types of lipomas, which, as you say, are very regularly used in your practice. Do you think that those subclassifications have prognostic value? Do they inform you as to when to operate or not to operate, and whether this child's going to do well or badly? Do you have a view on the prognosis associated with those different types of lipomas?
I would say that they indirectly relate to prognosis, because if that interface is blurred, for example, for transitional lipomyelomeningocele, a full removal is probably not feasible. Then we sometimes have to leave some adipose tissue and make follow-up for that. So those cases can recur in the long term, and the complete removal is probably not always achieved. So yes, indirectly it has to see with prognosis, but particularly related to the surgical management. So we use the classification not to make an immediate decision to operate or not, because we still see the clinical presentation and if they have progress of symptoms or they remain symptomatic. But once they're taken to surgery, the classification allows us to make the surgical planning. And for the cases that we can foresee that we won't make a full removal, then we do the most radical procedure that is safe for the patient without damaging structures.
Thank you very much indeed for that.
Thank you.
Again for your talk, and in the interests of getting everybody's talks in, I'd like to move now on to our next talk, which is from Sergio Valenzuela from Chile. And Sergio had a couple of initial problems with your talk, but I think those have now been resolved, which is great. So Sergio, thank you for joining us, and please tell us about surgery for the spinal lipomas.
Thank you, Dominic. Can you hear me well?
Yes, we can. Thank you very much. And we can see your
slide. All right. Well, thank you very much for the invitation. Just would like to share some of our thoughts about surgical approach. Since Martina had a very nice introduction and Kemal also, we'll go directly to surgical aspects of this pathology. So let's go on, Martina. I mean, Linda, thank you. About the lipoma of the filum. We can see here what Kendall was showing us, a fatty grossing of the final part of the spinal cord, which is called the filum, which perhaps from time to time was just unseen. But with MRI, we have seen many kids with different pathologies that are harboring the fatty films like this one. Next. So, even very early in the newborn, we can see a few signs on the echography, like you can see in the square here I'm showing. But of course, the MRI is going to be the gold standard to diagnose this pathology when clinically suspected. Next. And we'll see things like this one. Fatty engrassment from in the actual view, and directly a small lipoma trying to pull down the spinal cord. Next. So after we have some of the previous consideration, as Kemal said, if we go and decide that it's needed to go to surgery, we put this way our patient. Next. And we start looking for this fatty film, and this is our way. We open up just with a laminotomy, probably most of the cases, and if the kid is bigger, laminectomy, but a small opening, and we pull up the dura and we look for the filum. We use, of course, electrophysiology intraoperative to check out that you are really dealing with the root or dealing with the lipomatous filum. Next. Then we isolate exactly, looking forward, looking upwards and downwards, and under the microscope, always just separating the final roots with the lipoma. Next. This is our final view. We are just getting off the fatty film, and all the roots are conserved. Dura is we put these sutures to put them up, and then we can have a very nice closing of the dura. Next. So some of our observations. With the lipoma of the filum, cut or remove depending the site extension. Of course, subcutaneous lipoma usually is absent. Usually the aponeurosis is intact and the dural sac is normal. So we don't have to look for external or out of the dura abnormalities. So dura is open by a linear incision, as I showed. Sacral roots are adhering to pia mater, so be careful. Coagulation and section at the interface. We have to coagulate the filum because it harbors a very small artery inside, in the middle of the fatty tissue. So we remove the distal lipoma, and finally we have a tight closure of the dura mater. Next. So the problem is, as Dominic said, and probably we will discuss later, when to advise surgery by tether cord, in this case of filum lipoma. Well, the conus under 5, the level L5, or a distal syringomyelia, probably is one of the issues that is important to consider. The secondary is scoliosis, or a neurological bladder or rectus, which is worsening, or a feet abnormality, or pain in the legs related to exercise. We can have those considerations for indicate a previous surgery in a very small children, or older one, but with some of these clinical issues. So prophylactic surgery is yet under discussion. There are authors that recommended another, like the French school, that they say just wait and observe. Next one, please. Regarding on the lipoma of the conus, which is much more important and much more problematic to resolve. Well, Kenneth Kemmel already gave us a view on the Chapman or the classification, which has been for many years the way we used to look to this pathology. The caudal type, the dorsal type, the transitional type, it's all in our mind when we decide to go on for surgery. Next. The typical lipoma, as he said, fatty mass, the pedicle, the intraspinal part, the dural opening, the interface between the spinal cord, the medulla, and the lipoma, the medulla itself, and the roots coming out, and the adherents that always are present. Next. The dorsal type with the interface between the medulla and the lipoma, and the minimal intradural lipoma, as the figure shows, and the medulla sticking to the dural edge, like here, right here. Next. The dorsal one, the interfaces between the lipoma and medulla is far from the dural opening, like here. The great volume of the intradural lipoma makes it harder to get it off, and there are low adherence between the dura and the medulla. Next. So the dorsal lipoma of the conus looks like this on the MRI. Next. And when it's the posterolateral type, which is the most hard, in my opinion, because some of the roots are inside the intra-lipomatous, so we have to preserve them anyway. And on the other side, usually they are free. So there is a different view of the abnormality when we're under the microscope. Next. And the caudal type, there is an invagination of the medulla into the lipoma. The interface is posterior to the roots, so the roots come out in the front, and they are extra lipomatous. Next. So here we have a nice view of a picture of the book of Yamada, I think, or yeah, that shows us the caudal lipoma of the conus. Next. And the Lipomyelomeningocele, as Kemmel said, the medulla and the dural sac, they're all herniated out of the vertebral spine. Subcutaneous lipoma are adhering to the placoid surface, like here, and no dura between lipoma and medulla. So we have a problem in these cases with closing the dura, and usually we have to use grafts, different type of grafts. Roots are born on the posterior face of the medulla and are extralipomatous. So our problem is going to be the union in between the lipoma and the medulla. Next. And of course, the lipomyelocystocele, which is one of the most hard malformations to deal with. There is a syringomyelia with distal and cystic dilatation, which is shown when we just open up and we take off the fatty tissue, we will go into this big cyst herniation. The inferior part are closed by the dura mater and lipoma, here, the inferior part, right here. And there's no communication between the cavity and the subarachnoid space. So we have to be very careful in looking at the different planes and the different parts of this very, very hard malformation. Next. So what are our surgical objectives when we face one of these pathology? Is to free the cord and roots from their normal attachment to dura and lipoma, removing the mass as much as we can, but always preserving the neural tissue. And of course, prevent the retachment, which is going to be one of the main complications afterwards. Next. The principles are to operate under magnification always. The use of ultrasonic aspirator or lasers are of some help, but not 100% necessary. Intraoperative monitoring, on the other hand, is useful to distinguish functional roots, and we advise it to use it always. And of course, we have to consider the possibility of needing some graft or aponeurosis to enlarge the dural sac, because this is very well recommended to avoid retithering, which is one of the problems afterwards in the long term. Next. So intraoperative monitor, what for? Visual inspection, of course, we can be looking at the lower limbs when we have we can explorate the roots, the intravesical pressure with the bladder, and somatosensory bulk potential, because the posterior funicula of the cord are above the upper lipoma, is going to show us the patency of the nerves, and electromyography limbs on bladder ano. So no permanent monitoring, but in the moment that we are facing the separation of roots or the lipoma and the medulla, we think this is mandatory. Next. Just another view of the way it goes. Next. In our procedure, we start with the midline incision extended to 1 or 2 spinal processes above the lesion, usually vertical or elliptical incision over the dome, curved incision in lower lesions because of the proximity with the anus, W-shaped or horizontal incisions only when we have 2 wide lipomas. So incision must remain away from the anus because there is always a high risk of infection. Next. That's the way the incision. Next. Our way is to go this way, an incision which is enough to cover the big surface of the lipoma. Next. Then we go remove the fatty tissue enough to debulk, but leaving fat enough to assure tight closure, because sometimes we have to avoid dead spaces. So some of the subcutaneous fat we should leave on place. Avoid excessive coagulation. Yeah, we just can go having pushing on small vessels, but we have to avoid excessive coagulation because fatty necrosis is actually another problem in surgical in the post-op. Isolating the lipoma from the fascia and paravertebral muscles. Next. Laminectomy, or of lowest normal lamina, or perhaps, if possible, laminotomy, which is a very good possibility to maintain stability of the spine. If lamina are bifid or dura is exposed, probably we don't need none of them. It just wide open because separating them. And consider laminotomy in toddlers, exposing the upper limit of the intradural lipoma, basing on the image of the MRI. Next. That's the way we go on, separating the lipoma, the extra lipoma, and looking exactly where the place when the lipoma goes into the spine. Next. Then the dura, cut open in the middle rostrocaudal or circumferentially at the point where the lipoma ends the dura. That's the way we consider better, depending on the volume of the lipoma. Much care with the additions between the lipoma or the dural spinal cord and the dorsal roots. Some of the roots are very weird to go out. and they can have a very different trajectory from left to right. So we have to look for each one especially. And you use retention sutures to hold up the dura and have a better possibility to to look with our microscope. Next. That's the way we go. We separate the dura from the lipoma. Next. We go on, opening the dura and putting stitches to widen up. Next. And then we are working already inside. We have the opening the spine here. We have the medulla and we have the lipoma, the interface. Next. It's much easier in caudal or dorsal insertions because the posterior roots are extralipomatous, but very difficult in dorsolateral or lateral because the roots are malformed, short, intralipomatous, aberrant. Dura may be missing and replaced by fibrotic bundles. So additions, high roots from sargent and mimic nerve. So be very, very careful when cutting the roots or cutting the additions. We have to monitoring each one of these lines of tissue because sometimes they are just look like roots, but they're not. So roots are very dangerous or stop, and always intraoperative monitoring. Next. Well, now we are already getting off the lipoma and separating the roots from the nervous system and the spine itself. Next. Here we go. We're having dissection very, very light and always looking under the microscope and selecting the roots by one by one and monitoring. Next. In this case, we usually cut the filum terminale if it's close to our incision because it is one of the ways to make it better and avoid the reattachment or having this tether cord just primary or secondary. Next. So here we are already finishing. We have just finishing with the resecting the lipoma. Probably we're going to leave something in place. Next. And we start closing here. We are closing the aponeurosis. Next. And finally, intradermic suture. Next. And we finally do the surgery. So what's some of the recommended trends? From the neck care experience, is to leave enough spacious lipoma in situ to avoid dead space, dural incision rostrocaudally, stop if lipoma is too difficult, complete removal only is possible in about 66%, closure of the lipoma edges to not prevent late deterioration, so only it happens in 70%. And syringomyelic cavities, if found it, they're left untreated. Next. Also, dural closure with enlargement is advised to limit addition. As I said, we can use autogenic graft or heterogenic frag, but they're much better to use, even if possible, the fascia lata when the kid is a bit higher. So if dura is missing laterally, we can fix it to repair the paraspinal muscle or use the aponeurosis paralumbar. Release and mobilize the lumbar social fascia makes it easier. And at several level closure, which is more difficult, is useful to leave a major part of the subcutaneous lipoma to better the closing. Next. So if we look at the experience of Professor McLeod, which is a bit different from the French experience, but always resect lipoma partially before dissection in large fatty masses. Free the lipoma from dural edges, look for the interface, go to intramedullary approach carefully, resect as much as possible safely, and use ablation if it's needed. Next. Nerves exciting dorsally through the lipoma are not functional, so as well as the vessel. They may be transected, but carefully and always monitoring. Nerve passing inferiorly towards the foramina are functional. Those we have to preserve. Check if there is a thickened filum terminale and transected, because if it doesn't, it will keep tethering. PRPA sutures are possible to close myelotomy, prevents retethering, that can be discussed. Next. So final trends, dural closure carefully, reconstruct the dural sac, core must remain loose, closing overlying muscles, do not constrict underlying cord, this may be kept loose, layer of paraspinal muscles if it happens, avoid dead subcutaneous spaces, and skin with absorbable sutures. it keeps you off of the infection possibility. Next. So recent complication. In the care experience, there is a low incidence in lipoma of the filum, but higher complications in lipoma of the conus, up to mortality on 0.2%. So we have to be keeping that in mind. Local complications, about 25%, infections, subcutaneous pseudomeningocele, wound breakdown, or CSF leaks. Next. Neurological complications, about new symptoms or worsening on electromyography dynamic studies, transient complications, in about same 0.5%, all regressive, fortunately, but permanent in asphyxia-related in about 8%, sensory difference 3%, motor deficit almost 5%. In literature, permanent deficits account for in between 0 to 5%. So this is a pathology that must be taken care with very, very careful considerations. Thank you very much.
Sergio, thank you very much indeed for that comprehensive review of the complex lipomas. Interestingly, there was a question coming from the audience while you were speaking about how important is it to resect as much of the lipoma as possible. As you know, Dakling Pang very nicely demonstrated, I think, that partial resection of lipomas was probably no better than the natural history if you left them alone. So I think, of course, you then have this balance between doing radical surgery and surgery which is safe. So what's your take on the radical surgical approach?
Well, excellent question, Dominic, because what we have seen here in our practice in South America or in Chile itself, that if you leave an amount, a huge amount of lipoma in place, these kids get older and they grow a lot and they get fat and the lipoma fats and grows again. So under the same considerations of not damaging the spinal cord, we try to resect as much as possible. And what means possible? Possible means as long as you can, under the microscope, taken off safely and with intraoperative monitoring. But if you leave a bigger amount just because of you know that the probably is not going to grow, you may have what we have seen, the kids, they got fat. In Chile, it's very fatty kids are too common. So in my personal opinion, I try to do it, but safely.
Okay, thank you.
Dominic, we have to move on just because of time issues.
Yeah, no, exactly, Jeff, thank you for that. And thank you for your response, Sergio. So moving on now, we're going to move away from lipomas to split cord malformations, an overview of pathogenesis, diagnosis, and treatment. And it's my pleasure to introduce Samuel from Maine. So Samuel, the screen is yours. We look forward to hearing you.
Hi, everyone. Thank you for this opportunity to present this presentation. So let me share this.
Yeah, that's sharing now, Samuel. If you could go into presenter mode, that's perfect. Well done. Thank you very much.
Okay, so today I'm going to talk about the Diastematomyelia and overview of pathogenesis and diagnosis and treatment. So short introduction. So Diastematomyelia or split cord malformation, SCM, is a congenital spinal anomaly in which the spinal cord is divided longitudinally by a fibrous or bony septum. Regarding the anatomy and pathophysiology, this malformation originates from one basic error that occurs at the time of closure of the primitive neuroenteric canal and formation or persistence of an accessory neuroenteric canal between the yolk sac and the amnion occurs, creating the endomesenchymal tract that splits the notochord and neural plate. So I would like to present the two types of the Diastematomyelia, type 1 and type 2. And there are two types here. Type 1 consists of two hemichords, each with its own dural tube and separated by a dura, unsheathed rigid bone, median septum, and usually associated with cutaneous abnormalities at the level of the split, such as skin pigmentation and hypertrichosis, like hair patch, nevus, or hemangioma. Hydromyelia is also common for type 1, and vertebral abnormalities like spina bifida, hemivertebrae, butterfly vertebrae, fusion of lamina of adjacent levels. Usually symptomatic, presenting with scoliosis and also TCAS, tethered core syndrome. Type 2 consists of two hemichords within the same dural tube separated by a non-rigid fibrous median septum, and type 2 usually have no cutaneous abnormality at the level of the split. But spina bifida occulta is usually located in the lumbosacral region. So single dural sac and no rigid spur, but rather only a non-rigid fibrous or sometimes fibrovascular septum. Hydromyelia is also may be present for this type. Spina bifida may be present, but other vertebral anomalies are far less common than for the type 1. So less symptomatic or may even be asymptomatic, the second type. The epidemiology, our colleagues already presented that these malformations account for approximately 5% of all congenital spinal defects, and mostly it is located in lumbar spine from L1 to L3, but it is also common for thoracic, lower thoracic part, and typically it presents in childhood, and adult presentation is rare. Congenital anomaly caused by persistence of neuroenteric canal, and it can during the gestation period, and leads to sagittal division of the spinal cord or cauda equina. If the cord does not reunite distally to the spur, it is considered also diplomyelia. So it is through the duplication of the cord. And the clinical manifestation I would like to present. Loss of continence after toilet training, it is constipation and scoliosis. There are the most common symptoms beyond infancy. Complaints of intermittent back or leg pain also can be associated with these symptoms. These patients may have normal neurological exam sometimes, but physical findings such as asymmetry of foot, for example, muscle atrophy, pes cavus, deformity, calf wasting, atrophy, especially the gluteus muscle atrophy, lower sacral hypostasia, and mild scoliosis can be common manifestations for this disease. And physical examination can reveal the reflex asymmetry. Also, we can see on the right side the hairy patch, like hypertrichosis, subcutaneous mass, and for the lower extremity deformities, it can be cavus foot, club foot, or claw toes. One question, it is related when to do the surgical, to perform the surgical intervention. If the children have been symptomatic for 6 months or less, it can generally expect improvement in their symptoms. On the other hand, if they are symptomatic for 1 year or more, may often have stabilization of their symptoms or deficits, may have they may have less chance of neurological improvement. So the best management for asymptomatic is neurological normal children with incidental findings on imaging remains still controversial. whether these children undergo surgical correction or not, it is related to their follow-up also. If we have any worsening of the neurological conditions, then for sure we need to perform it. Some diagnostic techniques, and this is first of all, it's prenatal ultrasound in utero during the third trimester. It can reveal abnormality before the birth, but after the delivery, like postnatal diagnostic imaging can be X-ray, myelography, CT scan, or MRI scan. So some X-ray pictures here, you can see. The next one is myelography. And then we can see the CT scan, where we can see the level of the diastematomyelia, and MRI. So here, the diagnosis of this disease, diastematomyelia, in the newborn usually occurs after the recognition of midline cutaneous anomalies such as an intergluteal sinus or dimple, tuft of hair, hemangioma, cutis aplasia, or sometimes subcutaneous lipoma. So it may also be seen with the myelocystocele, the recognition of asymmetrical lower extremity motor exam in the newborn baby with other spine defects should alert the clinical neurosurgeon or neurologist to find out the possibility of the associated diastematomyelia. Associated anomalies can be for approximately 80% of the cases. It can be also congenital scoliosis. It can be tethered core syndrome, and also the syringomyelia, which will be recognized on the preoperative MRI especially. So the next one is, I would like to share the MRI image with the T9, 10, and 11 level of diastematomyelia, and also the tethered core syndrome here, the fixation, so it can be associated anomaly. This is one of the cases recently we performed. For the treatment, conservative management via the surgical intervention. So MRI in association with the diastematomyelia can reveal the problem, and the general plan can be the fenestration if there is a searing, for example, at the time of untethering, if it's large, and in the proximity of the diastematomyelia. Otherwise, it is recommended that the searing will be followed with the interval MRI scans. If spinal radiographs show spina bifida occulta and widened pedicles and may define the bony spical, the urodynamic studies commonly can reveal also neurogenic bladder. So for the CT scan, axial CT scan is important for the preoperative understanding of the bony anatomy, as I've already shown during the diagnostic techniques. And MRI may identify a thickening of filum terminale and associated syringomyelia, which will allow the surgeon to plan for an incision long enough for simultaneous sectioning of the filum and fenestration of the syrinx if it's large and if it's proximal to the CSM. So careful evaluation of the imaging preoperatively is necessary to determine the type of the diastematomyelia and location of the separation of the hemichords and the bony septum, bony or cartilage. Perioperative antibiotics are given prior to the incision if we are going to talk about the surgical intervention. And the anesthesiologist should use a short-acting muscle relaxant during the induction to allow for intraoperative neuromonitoring, which we usually use for these cases to do the surgical intervention. And it can recognize the motor response in inadvertent stimulation of the nerve roots, and intraoperative spinal cord monitoring is very important for this surgery. So usually for these surgeries, patient is placed in the prone position on chest rolls extending from the chest to the iliac crest, and this prevents abdominal compression and also the secondary distension of the epidural venous plexus and decrease venous bleeding. The patient is then can be placed in a slight Trendelenburg position to prevent excessive loss of CSF during the procedure, and extensive preparation and draping should be performed to allow for extension of the incision. And to go deeper, I would like to present the laminectomy at the level of the malformation, and one level up above and one level below is often adequate for the repair. The dura of both hemichords then can be exposed. The bony septum of the CSM can be quite vascular, and it can cause a bleeding. But it can easily controlled also with bone wax, and the bony septum is then removed with a small ranger or a high-speed drill down to the posterior longitudinal ligament. A diamond burr helps to minimize bleeding from the septum also. Next, the dura is opened in the midline above the level of the malformation and leading into a midline dural incision below the level of the defect. The ventral segment of the dura separating the two hemichords is approximated if possible, and then with fine sutures and knots it can be approximated. This is done in order to recreate the floor of the spinal canal and prevent the regrowth of the bony septum in a patient. So next, the hemichords are explored for tethering adhesions ventral and dorsal, which are taken down with sharp dissection using, of course, micro scissors and, of course, sometimes knife. Strict hemostasis is obtained, and then intradural space should be irrigated with saline, and the dura will be closed with sutures. This will create one athecal sac containing both hemichords. And the epidural space is irrigated with bacitracin in saline, and the epidural veins are coagulated if necessary, because sometimes it can cause also epidural bleeding. Dural sealant may be also used as well, and layer closure, of course, of the paraspinous muscle and fascia is can be performed with interrupted sutures. Then the skin, of course, will be closed. And I would like also to share some postoperative care and prognosis related questions. The patient is discharged once the baseline neurological status is obtained. So it is important to remember to place all patients on a stool softener because of the constipation, because constipation secondary to narcotic medications is also a common complication after these surgeries. And once postoperative muscle spasm has resolved in the child, preserving with scoliosis, sometimes repeat X-ray of the spine will generally show several degrees of improvement in the scoliosis for the future. This improvement may be significant enough to evade the need for spinal instrumentation. Also, the question related to syrinx rarely requires shunting and usually does not progress if the untethering is successful. So these are the main aspects I would like to cover during this presentation. And the last but not the least, I would like to invite each and everyone to visit our country, and they're always welcome to come and to share your knowledge and experience with us. Thank you.
Wonderful. Thank you very much indeed, Samuel, and thank you very much indeed for keeping to time. No immediate questions at the moment, but maybe if I could ask you one question. You explained very nicely at the beginning the difference between type 1 and type 2. Maybe I missed it, but do you manage those cases significantly different? Would you recommend surgery for all of them, or do you think there's a prognostic difference there?
It is of course different on the diagnostic from the diagnostic aspects. Like we can see different types on MRI, for example, but usually we consider both from one aspect for the surgical intervention in order to do or not, because it is related also to their neurological condition and the symptoms, neurological symptoms, which they have for both sides, both types.
Okay, thank you very much indeed. Well, look, I think on that comment, thank you once again, and I think we're going to move on possibly to an even rarer dysraphic anomaly now. Tamara Portillo from Paraguay. Thank you very much indeed, Tamara, for joining us and giving your thoughts on this phenomenon of terminal myelocystocele. Thank you. You're muted, Tamara.
Hello, sorry.
That's it. Well done.
Hello. I'm so happy to be here with all of you. This is sorry. Well, I'm Tamara Portillo. I'm from Asunción, Paraguay. Thank you so much for this opportunity. I am very grateful. So when we see this kind of patient in our consulting with a skin cover mass, lumbosacral mass, our first thought generally is that mass is as a spinal lipoma. But we also have to think in other pathology that is terminal myelocystocele. The terminal myelocystocele is a rare form of occult spinal dysraphism that consists in a cystic dilatation of the central canal of the distal spinal cord that is herniated through the posterior spinal bifida. This dilatation of the terminal canal doesn't communicate with the subarachnoid space and is surrounded by a meningocele. It's a rare form of lumbosacral spinal dysraphism. Occult spinal dysraphism represent only 4 to 8%. Some papers say less than 5%. The location in lower thoracic region is rare, appears sporadically, no familial incidents, no true preponderance by sex, but there are described some teratogens that hydantoin, loperamide, and retinoic acid. The embryology is due to an apoptotic failure during late secondary neurulation that is corroborated by Pang through his work on chick embryos, and he proposed that the terminal myelocystocele is resulting from lac apoptosis just before the planned dehiscence of terminal bubble from the cutaneous ectoderm. Pang also described the features essential and non-essential to define a terminal myelocystocele, and the essential features are: the caudal spinal cord is elongated, its terminal part extrudes into the dorsal extraspinal space and fuses with the subcutaneous fat. The extrude part is a trumpet-shaped CSF field cyst, and the functional conus is rostral of the extrusion. The skin is full thickness. We can see in this MRI all the essential features with the elongated spinal cord, and the contact with the subcutaneous fat. And we also can see the hydromelia and the meningocele. The non-essential features are the hydromelia, the size of the subarachnoid space, the amount of subcutaneous fat, and the sacrum. All of them are variable. In this MRI, we can see the expansion of the sac that fill with CSF, the plateau, and the roots with the elongated spinal cord. This expansion of the sac can occur, and the why occur that is not well known. In this other MRI, we can see the dorsal hydromelia. This is a case, a patient present with a giant terminal myelocystocele. We can see the large sac field of CSF and the elongated trunk-shaped spinal cord, the all essential feature of the terminal myelocystocele. How the terminal myelocystocele present? Usually present like a lumbosacral mass with good skin cover, and the mass is filled of fat, CSF, and neural tissue. The skin is normal or maybe show hemangioma, nevus, or hypertrichosis. The intergluteal fold is commonly obscured and distorted. Can be a neurological deficit or can be normal, neurogenital bladder or continence, but the intelligence is normal. The diagnosis is done by an MRI. In this case, with unusual presentation, they present a 4-year-old Asian girl full term who born without deficit and without an obvious back mass. And diagnosis was delayed until sphincter disturbance and a lower limb inequality developed. And we can see this MRI with the characteristic of terminal myelocystocele. The diagnosis prenatal is possible, and in those cases, it's important to repeat the MRI at birth. Can be associated anomaly like anorectal symptom of the lower genitourinary system, like Currarino syndrome, caudal regression syndrome, sirenomelia, and the most important, the most famous is the OEIX complex. Can be associated too with Chiari-1 in 10 to 15% of the cases, Chiari-2 in 1%, hydrocephalus and hydromelia. The different diagnoses are spinal lipoma, teratoma, and hamartoma. The treatment. In this case, the surgery is important as soon as possible to prevent neurological deficit because of the possibility of the expansion of the sac. And the objective of the surgery are cosmetic and the most important, detecting the spinal cord. And these are the most important steps of the surgery. Separate from the subcutaneous gland, exposure the normal dura by a laminectomy of at least one level cephalotudy defect, urotomy to reveal the normal spinal cord, the neck of the trumpet, and the flare of the trumpet that is attached to the subcutaneous fat. This is important, expose the normal part because the anatomy is very altered. It's important to start to the normal. Identify last functioning sacrum rootless and functioning conus by intraoperative electrophysiology. Determine the margin for maximal self-preservation, excision of non-functioning part of the spinal cord, PL reconstruction, and duroplasty, watertight duroplasty. We can see here all the steps, and if it's possible, it's important to do a MRI postoperative to rule out hematomas. And this work of Pan, he present a series of 10 patients with the diagnosis of terminal myelocystocele, and he divided into groups, 4 newborns and 6 other children. All the newborns were neurologically normal, and the older children had neurological deficit. So that's why it's so important to do the surgery as soon as possible. In the postoperative, the recommendation is place the patient in prone position and elevate the leg end of the bed during at least the first 3 or 4 days. Acetazolamide is described in some papers, intravenous antibiotics for 2 days, and the complication postoperative, the most common is pseudomeningocele and CSF leak that can be treated conservative. The retethering is not described. The outcome is very variable, directly related to the neurological status at presentation. And when the terminal myelocystocele is associated with other anomalies, the deficits are more severe and the prognosis is less favorable. So that's why a close follow-up of this patient is mandatory. In this paper of Gupta et al., they present a series of 17 cases and report deficit in 47% of the patients. In the follow-up of at least 1 year, he described the improvement of the deficit. And this other paper from Muthukumar, he present 14 patients, a series of 14 patients. 10 of the 14 patients have some form of neurological deficit, and we can see in the outcome and follow-up, the majority stay with the same deficit. And this other paper from Italian hospital from Buenos Aires, they present a series of 6 patients, all with prenatal diagnosis, and all baby was surgery in the first week of life. All the baby have normal spontaneous movement, 4 of 6 associated anomalies, and the outcome we can see 4 of the 6 have neurogenic bladder and walk with assistance. So with the terminal myelocystocele is a heterogeneous group, and the outcome and the presentation is so variable. In our experience, this is my hospital, IPS Central in Asunción. It's a general hospital, but we have a lot of cases. In this year, we see until now 2 cases. The first case is a female full-term born with prenatal diagnosis of a lumbosacral spina bifida and multiple malformation. The diagnosis at birth was regression caudal syndrome, cloacal strophy, agenesis of left tibia and peroné, and the lumbosacral ocular spinal dystrophy with a high suspect of terminal myelocystocele. 1 week later, the baby developed acute mesenteric ischemia and sepsis and almost died, but always have a spontaneous movement. With 20 days later, the sac grows inside, turn blue and tense, and because the baby gets better, we can do the MRI. And this MRI, we can see the Chiari-2, no hydrocephalus, no hydromyelia in other levels, but we can see the large sac and the trumpet-shaped elongated spinal cord. This is called the target sign described by Muthukumar and represent the hydromyelic cord within the meningocele. I don't have picture of the surgery. In this second case, present at consultation a 5-month-of-age male full-term born that at that moment had neurogenic bladder that needs intermittent catheterization with myelolymph weakness. At birth, he presents urinary tract infection and pulmonary hypertension and was hospitalized for 2 weeks. This is his MRI. We can see again the elongation of the spinal cord that is attached to the subcutaneous fat, the hydromelia lumbar, and a little myelocystocele. No hydrocephalon, no hydromelia in other levels. The CT scan, we can see the spina bifida lumbosacral, and this is the surgery, prone position. We did a middle line incision, respect the sac, laminectomy or 2 level up. We open the dura, and here we can see the altered anatomy with the columns and the roots rotated to the right, attached to the sac and subcutaneous fat, with the tethering the cord, and did the neuralization, and then the duroplasty catheter. This is the final result. Our teen old woman, and the baby now is almost 2 months of the surgery, and the movements are improving. For conclusion, we have to think in the terminal myelocystocele when we see a lumbosacral mass covered by skin. Understand the embryology is essential because the anatomy is very altered. MRI of the brain and the entire spine always to rule out other pathologies. In case of prenatal diagnosis, a new MRI at birth is important, if it's possible. The treatment, surgery, always, early as possible, to prevent neurological deficit. Intraoperative electrophysiology, always to define the nivels and this safe excision. Outcome is variable, so that's why a close follow-up of this patient is mandatory. Thank you so much, and you all are invited to Asunción anytime.
Tamara, thank you very much indeed for a detailed overview of an extremely complex pathology. And I think as you demonstrated, the anatomy there in the surgical anatomy of terminal myelocystocele can be really formidable. And I think it's a good demonstration of where the electrophysiology monitoring is absolutely essential to allow you to know where you go from functional to non-functional. And I think you also nicely demonstrated the risk of early deterioration. And this is the one group of occult dysraphisms, I think, where deterioration can occur very early, which I think you well demonstrated. So thank you very much for that. We're just, I think, within time, so I'm going to move on now to a different pathology, a much simpler in a way surgical pathology, but actually one where the surgical decision making, I think, is probably where a lot of the discussion might be. So Alessio Costaval from Brazil, thank you very much for being part of the panel for this, and we look forward to hearing your thoughts on thickened filum terminale.
Thank you, my friends. Are you listening?
Yes, we can hear you well.
Okay.
Share screen, I'll just confirm that we can see you.
Okay, so I'll share. Just a minute. Just a minute, I'm having a problem here.
Okay. if it continues to be a problem, Aloysia, what we can do is you could just send it to Linda at the office.
Okay, and I think it works now.
Almost there. You may be on a different screen.
Oh,
There we go.
Maybe maximize that, yeah.
does it work?
Yes.
Look-
Oh, wait.
Okay.
Back to the beginning. Yes, and if you come to screen, that's lovely. Well done.
Perfect.
Okay.
Far
So
away.
thank you very much, my friends, and thank you, Arthur, for the organization, and thanks ISPN. I will discuss something about the tight filum terminalis. The first thing we should know is what we call tight filum syndrome. That is exactly the same of other Tetris syndromes, but associated with a short, thick, or fat, and or non-elastic filum. So sometimes it cases the tethering, and sometimes even without a low-lying conus medullaris. But what is the conus medullaris? This is that structure that we see usually very benign in procedures, other procedures that we need to approach the caudequina, but other times they are very robust and different like that, completely different of the traditional structures that we find in the lower caudequina. So that's what we'll talk about. And we should remember something of embryology. Everybody is very familiar with the primary neurulation that leads to anencephaly and the spina bifida. But the filum terminalis results from the secondary neurulation. It's a very complex process, and we don't understand it completely in humans. But what's happened is during the gastrulation, a portion of the mesoderm remains in the distal space, and it condenses into a solid rod called the caudal eminence. The caudal eminence later develops a lumen, and at the end of the 6th week, this structure funds with the narrow canal and then regress. And that's the all chart. We have just after the primary neurulation, in the junctional neurulation, all the process that leads to the formation of the filum terminalis. This a nice illustration. So the secondary illustration begins as the completion of the primary neurulation after the closure of the caudal neuropore and forms the filum terminalis. And the anatomy, what we know about the normal anatomy of the filum, this is a very nice work of Fernando Gomes that is studied in human adult cadavers. And this is the main conclusions that they find of the filum. And this all work also that were done in 10 fresh and 10 unbound cadavers. And it's what we should know, that we have 2 layers of the segments of the filum terminalis. The internal that goes to the conus until the dural sac, and the external, what's also called ligamentum coccygate, that connects the distal dura to the sac to the periosteum of the coccyx. So here we can see the internal and the external part of the filum terminalis. The internal results from a differentiation of the most caudal parts of the spinal cord, and even the external part seems to hold neural tissue as well. And the 2 parts are not ligaments; they are parts of the central system. And I recommend this article to know more about the anatomy of the filum. And the tight filum syndrome is very alike other syndromes of tethering. We almost always find the cutaneous stigmas, very different cutaneous stigmas, even tails and dimples, and orthopedic and urogenital and neurological symptoms like that. And even malformations like that. So we should be very attentive, and the pediatrician should be aware of all these signs. We can study with ultrasound. It is very nice in young babes, and has correlations with the MRI and the surgical findings. X-ray and CT you can use to study the spine, but always concerned if it's really necessary because of the radiation in a young child. The majority of the times we do not use it. And of course, the MRI is the gold standard. We can see very clearly in the majority of the case, the conus, the filum, the caudequina, and also other findings. And there are very signs we can look and the correlation with the surgery. And we can study the hydromyelia and the syringomyelia. And we see this kind of very stretched spinal cord and the fifth ventricle as well, and very robust filum. And in the right, a very stretched spinal also. That's very usually associated with scoliosis. So when to treat? And that's the very difficult answer, $1 million answer. There is a huge and old and recurrent and inconclusive debate in the literature. Should we be prophylactic? Should we be symptomatic? Or should we operate it and it worsen? It's very difficult to answer that. I can refer this work of the people from Birmingham, and it's I like very much to hear that the challenge that faces the neurosurgeon does not lie in the technical aspects of section the filum, but the correct identification which children have a tetrachord syndrome, which children are the risks of tetrachord and future neurological deterioration, and which children would benefit from surgical intervention. So there's no easy answer. I think all cases should be studied, examined, and it's a difficult decision, always a difficult decision. And the surgery, the simpler is better. 1-2 laminotomy levels, minimal dural open and maximal closure. So a very little skin incision, you can treat the tail, for example. And also 1 or 2 laminotomy needles, just in the part you can choose exactly in the above the filum. You see you can see the filum by transparency, and identify, isolate, test. I think we'll discuss that. I think it's very important to test, to monitor, and cut the filum and restore the spine. So that's it. Very, very little access, and this is a old case, just to show that sometimes it's even difficult to open, because you see it's a fat tight, and there is hypertension inside the canal. So we, after open the dura, we isolate it and put it's a nice structure to work then. So we isolate from one side to other. It's important to coagulate because there are vessels inside, and then we pass some straps and cut it. Like that. The role of monitoring, some people says that it's not very important in all cases, but I use it in all cases, and I think it's help us even to some case where the filum is not very different from the roots, and in other case, we can have roots attached to the filum, and it's necessary to dissecate and to be sure that attached. So the monitoring is I think we should have it in all surgeries, because we never know when we'll have problems like that. And it's really important to be sure that you will not cut some roots or some that. And sometimes just looking in the microscopy, it's not so easy to identify. After the surgery, we restore the spine. We can use so many techniques. And is it effective? Is it safe? I think so. This is the girl we saw as a baby 5 years later, and she's now 90 years and is studying for a medical doctor. So she had just one surgery in all her life. And okay, it seems to be effective for many objectives, as for example, to treat the syringomyelia. And we don't have so many complications because it's not the most difficult operative that we have. And retethering is not common, but it occurs. We can discuss this also, and especially with cicatricial adhesions. What we saw is the symptoms recrudesce, and we find a suggestive image like that. And we just open again and release the arachnoid adhesions, and also always with good results, as you can see here, before and after the potentials getting better. And one discussion is the section of the filum to Chiari and other pathologies. As we all know, there is some people that offer that to the patients, saying that we have get better for so many things. And the Brazilian Society has decided to study that, and we made a consensus that's the promises of the colleagues. And we have this consensus about the surgery, because we are having a lot of problems in Brazil of the indications, and even the people wants that the government paid to go abroad to have the surgery. So the task force conclusion was that such procedure is not sufficiently supported by scientific data and should only be indicated for exceptional case, mainly if there is a concomitant tether cord. So I thank you very much for your attention. This is my house in Nova Lima, Minas Gerais in Brazil, and this is Mendoza, Vale de Uco in Argentina, when we have very good wines. Thank you very much.
Alessio, thank you very much indeed for that. I think salutary lessons, as we were saying, I think phylum, one of the main things is really knowing when not to operate. And I think it's a good area where it would be so good for us to have some more natural history studies for phylum, and perhaps, collaboratively sometime in the future we'll be able to achieve that. Because, we always, these surgeries, the children tend to do well, but of course, would they have done well without the surgery? But thank you very much for that. And so I think we're doing just about nicely on time. We're a little bit over, but if I could move, if you don't mind, on now to our final speaker. And now we're going to finish off with Manas Panigare from India. And Manas, you're going to tell us about the timing of surgery in occult spinal dysraphism. So thank you very much indeed, and welcome to the seminar.
Thank you, Dr. Dominic, and thank you, Dr. Jeff and Dr. Arthur, for giving an opportunity to participate. I think most of my talk has been covered in each of the topics, when to operate in lipomeningocele. So I'll give a short talk of timing of surgery. And as I understand, this is meant for medical students. I've made it very simple and outline so that the medical students can understand. Let me tell first about the relevance of this topic. Over a period, the incidence of occult spinal dysraphism has been increasing with the use of folic acid, and because of the availability of investigations like MRI in developing countries, the detection rate also is higher, and hence we come to the conclusion that if we detect when to operate, whether to operate early or follow them up. If you look long back in literature, open spinal dysraphism was 95%, and the occult was supposed to be 5%. But with countries having mandatory folic acid fortification, the incidence has significantly come down, that the anencephaly has come down, and the spina bifida, this is a paper from India, they have come down, that the open defect has come down to 72%, and the occult spinal dysraphism is almost 25 to 30%. So what are the controversies regarding surgery? Because we do not know the natural history of the occult spinal dysraphism, like filum terminale. Hence, we have confusion that when to operate, or operate when the patient is supposed to deteriorate. There are anecdotal reports that when a child with tethered cord can go into adulthood without developing any dysfunction. And they develop deficit because of traction on the conus as when they grow. But all the time, many of the patients, like 60% of the patients, do not develop any symptom, and only 30 to 40% over a period of 10 years, the asymptomatic tethered cord patients can develop symptoms. So when 33% only develop symptom, is it worth operating for all of them? And how to detect those 33% which will worsen when we follow them up? Now, how to increase the detection rate is to to teach the medical students how to detect the occult spinal dysraphism. As a medical students, all of us see this kind of mark, but this kind, do we go for MRI for all patients who come with a scar, with a dimple or a tail or a tuft of hair in the back? There can be portoine stain, hemangioma, there can be deviated luteal fold, hypertrichosis, dimple, or pigmentary nevus or a lipoma, but all of them do not warrant an MRI. Now, this was a paper where they reviewed 54 cases, and what they found was when you have a single lesion, the chances of finding a positive MRI is less, but when there are two lesions, the chances of finding a positive MRI increase significantly. So when children had two lesions, 11 out of 18 patients had a positive MR, whereas there is a single lesion, only few patients had a positive MR. Hence, they classified into three groups. That group 3, people who have only hemangioma or hypertrichosis or single or Mongolian spot, they do not need MRI because they have a low risk of having associated occult spinal dystrophism. Whereas group 3, when they have 2 lesions of any kind or 1 lesion and spinal cord dysfunction, or they have a weakness or scoliosis or any neurodeficit, or a lipoma or a dermal sinus and tail, these are the high group patients, they have to go for MRI. But in group 2, when you have an hematoma or a atypical dimple or deviation of the gluteal furrow, we don't have to ask for an MRI in less than 6 months because we don't want to give anesthesia for children to do MR. One can do an ultrasonography, and if it's abnormal, one has to do MR. But if it's normal, one need not do. So as a medical student, one has to learn when to ask for an ultrasonography or when to ask for MRI to detect an occult spinal dystrophism, as it's important to detect early so that it can be treated early to prevent any deficits. Now, a high-resolution ultrasound can be done for the newborn till 6 months, till the bone is fused, which can detect many of the occult spinal dystrophisms. Now, this is a second case scenario. Many times, children come with urinary voiding dysfunction or recurrent UTI. Now, all the children with this urinary dysfunction, do they need MRI to exclude occult spinal dystrophism? Now, this paper came long ago that doing a routine MR for urinary dysfunction does not yield a positive result, but urinary dysfunction with a skin marker may yields a positive result, and those cases needs MRI, but only with urinary dysfunction, unless there is an associated neurological deficit or an orthopedic problem or a limb asymmetry, do not need an MRI. So this paper came in 2012. They said that there is a sacral skin lesion with voiding dysfunction. They need an MRI to, even if the neurological examination is normal, to exclude an occult spinal dystrophism. Now, having diagnosed early an occult spinal dystrophism, what should be done? Now, this is long ago. It was published in 1998. They had divided into 3 groups. Group 1 is asymptomatic, where surgery was not offered. And group 2, patients who are children who were born with upper motor neuron symptoms. They were followed up, so who did not have any deficit, but they were operated when they developed UMN symptoms. And group 3 was surgery was done when already symptoms was there. And in that paper, they suggested that asymptomatic patients should not be treated, and only symptomatic patients needs to be treated. But there is no actual data to clearly support that prophylactic untethering in asymptomatic patients help. And in that study, they prospectively studied to investigate if a patient is operated on appearance of a sign, is it better? But the reversal of deficit is worse when a preoperatively child already has a deficit. So always it is better to operate in asymptomatic patients so that the outcome is better. Now, if one decides to do a follow-up in an asymptomatic patient, how does one do a surveillance? One can do a serial cystourethropy and urodynamic assessment, or do a serial SSCP of the posterolateral nerve, or do an MRI of the spinal with phase contrast to look for spinal cord mobility in flexion and extension. And if one demonstrates there is tethering of the spinal cord, then even though they are clinically asymptomatic, they should be operated. Many of the patients, if an example of lipoma is taken, if they are operated early, they have a 10 years outcome, good progression-free outcome of 80%. But if they are not operated, there is subtotal excision is done, total excision is not done, then they fare worse than the natural history. Hence, many authors have promoted that if surgery cannot be done properly, it's better to do follow them up rather than going for surgery and have a worse outcome. As you can see in this paper, whenever there is a partial resection of lipoma, they had a 67% of bad outcome as compared to 90% who had 98% who had a good outcome. And follow-up was better than doing a subtotal excision. As in this paper, progression-free survival in partial resection was 43% as compared to 67% in non-surgical series. So if one is not confident of doing a total excision, probably a natural history observing is better than going for surgery in Lipomyelomeningocele. But in 2015, later after a few years, the Pang came that there is surgery has to be done for even for all Lipomyelomeningocele, irrespective they are symptomatic or asymptomatic, as the results are better if they are done early. But then he had classified that especially surgeries should be done lipoma with the filar or transitional and dorsal lipoma. They need to be surgery has to be done early, whereas complex lipomas or chaotic lipomas, where high chance of having a deficit are there, they should be followed up. So but this should not be taken that all of them need prophylactic surgery. One should be clear that which case has to be operated depending on the MRI finding and which case should be observed, as that can cause higher post-op deficits. I mean, this similar finding was also published from India, and they in 2019, and they concluded that doing early surgery or a prophylactic surgery was better than waiting for neurological symptoms to appear and then operate. In conclusion, among the occult spinal dysraphism, if a patient has dermal sinus or an infective dermoid, there is no controversy that they have to be operated early. But controversy exists if there is a lipomeningocele or a myelocystocele. Controversy exists in lipomeningocele, especially lipoma and diastematomyelia. But according to Pang, even the spinal lipoma, even if it is asymptomatic, it's better to operate, except in complex lipomas. And to early detection of occult spinal dysraphism, this is a good way for the students to understand that if there are two lesions of two skin lesions or one lesion with associated deficit, or if there is dermal sinus or lipoma, it's better to do MR. And if you have atypical lesions, better to do first ultrasonography in less than 6-month child. And if it's abnormal, go for MR. And having a single lesion probably doesn't need investigation to look for occult spinal dysraphism. And if one decides to do follow for asymptomatic patients, then every yearly urodynamic assessment, an SSCP of the posterior tibial nerve, and to look for spinal cord mobility with phase contrast MRI probably will help in early identification and treatment for asymptomatic patients. Thank you for your attention.
Manas, thank you very, very much indeed. You've kept us perfectly to time. I think we're literally virtually just at and I think you nicely actually brought together a lot of the themes that have been coming through this evening's seminar. I think the one thing for the students who are listening to take away, you've seen that there's a wide spectrum that provides this whole subject of spinal dysraphism. But that spectrum is also a spectrum of different natural history. And it's also a spectrum of different surgical complexity. And it's very rare that these cases, apart from what Tamara showed us about the myelocystocele, most of them do not require urgent surgery. So you'll have time to think, and your decision to operate will be very much based on your personal experience and your environment in which you work. And you should not be embarrassed or ashamed of that. You know, surgery is it's a learning curve. And in these cases, the line between between achieving benefit and causing harm can be a very narrow one. So with those final thoughts, I'd really like to thank all the speakers for their time, for giving really such an eloquent description of surgery and these really difficult conditions. Arthur, great job for putting together this really comprehensive overview of, and we've done a lot actually in a very restricted period of time. And Jeff and Linda and ISPN, thank you too. So Jeff, I don't know if you've got any final concluding comments, but as I say, thank you very much for inviting me to moderate. I've thoroughly enjoyed it.
Dominic, it was great to have you as always. You always bring such a thoughtful approach to it, and I really echo exactly what you said about the spectrum of these lesions. We commented at the beginning how challenging they can be, and I think a careful listener got a sense of that, that even between the presenters today, we heard a range of preferences, that we all still bump up against some very, very difficult things. When to stop, right, in the midst of a lipoma if the intraoperative nerve monitoring is acting up and chattering. You know, do we stop and leave a partial untether, right? When to operate, knowing that not all children deteriorate, but probably more than half do. Just talking about the conus lipomas, of course, right? What about redo surgery for lipomas? That's a whole nother challenging area. You can see, the learners can see how challenging this area is. And I would just submit that there's not a single lesson here, but just as Dominic said, that it's a journey for each person, and you'll do best by it by being dedicated to it as our speakers have. Arthur, again, would you care to make a comment or two at the close? This has been your work, and you've been the silent workhorse here, my friend. So thank you for all your work and your dedication.
So thank you very much. Thank you, Dr. Dominic. Excellent coordination. And thank you, my colleague that come to cooperate with our education committee. And I can announce the next web seminar for 27 September. And I think the topic is craniofacial malformation. That's it, Jeffrey? Yes. So, right. Okay, then thank you very much all. Wonderful with time, with topic, everything was really fantastic. Thank you so much.
And we'll conclude the seminar here. I just want to say that ISPN is very, very interested in student members and young doctor members. So go to the website. Membership is something that we really are prioritizing to try and support you in your growth and learning of pediatric neurosurgery. So thank you for attending. Thank you very much to the speakers. Manas, especially to you, it's middle of the night there. You're away from your bed. The rest of us are at least at some presentable hour. So thanks to everyone for a lovely seminar, and we'll see you all soon.